Thank you for joining us for Talking Sleep, a podcast of the American Academy of Sleep Medicine. I'm your host, Dr. Seema Khosla, Medical Director of the North Dakota Center for Sleep in Fargo. Today's episode is sponsored by Takeda. For 8 seasons of Talking Sleep, we have been trying to create educational content for our sleep medicine colleagues. Imagine our surprise when an engineer reached out and suggested talking about patient-facing platforms and how useful he found them. David Messerschmitt is a retired engineer who has been using platforms like SleepHQ and Oscar to better manage his sleep-disordered breathing. His colleague, Stuart Crisp, is a super user on the platform and has shared his insight with thousands of people trying to better understand their sleep apnea and the data from their PAP devices. Both are engineers from opposite ends of the earth and are here to share their knowledge and expertise on the various patient-facing open-source PAP platforms and how they use these data to improve their sleep apnea treatment. David Messerschmitt is a retired computer and signal processing engineer and has been active on SleepHQ for years. Stuart Crisp has a control systems engineering background and is one of the most active users on the SleepHQ platform. By way of full disclosure, they did try to reach out to the creator of the SleepHQ platform to invite him to join us, but were unsuccessful. Welcome. We're so happy to have you here today.
Thank you.
Great to be here. Thank you.
So I will say that we do receive emails from non-sleep clinicians, but I think a majority of those are trying to sell something, right? They're self-promotional, they're trying to sell a service or a product. And David, I think when you emailed me, I had mentioned to you that we have had a few sleep medicine colleagues ask about these patient-facing platforms, but we were just never able to find somebody who is knowledgeable enough about them to talk to us. So we are very eager to learn from both of you. Maybe should we start with SleepHQ? Tell me about SleepHQ.
Well, SleepHQ is a global community of users, probably 100,000 plus.
Oh, wow.
On a cloud-based platform where data is uploaded from CPAP machines and from other devices that the patient has and is available for viewing with visualization tools and has tools for sharing amongst patients. And then its main role is as an online forum where various patients talk to each other and help one another out with their challenges.
Stuart, what are your thoughts?
SleepHQ is a platform that is used. Look, there's 2 out there. We're not pushing either one of them. I don't represent, or David doesn't represent either one of them. Oscar and SleepHQ have different strengths, where SleepHQ is web-based, Oscar is not. But they both do very similar roles.
So you guys have been active in these online forums, which I think maybe started on Facebook. Is that right?
My activity with SleepHQ started in the Facebook group that became associated with it. But there are other forums out there, and I started with Apnea board before that, which is associated with Oscar.
So what kind of role do you see for these forums, sort of in the context of the overall sleep clinical spectrum, right? From clinic and testing and clinicians to then this community that you have described.
Well, let me give my starting point on that, and then Stuart can give his perspective. It's the question that I have in my mind is what happens to a patient's therapy after they leave the sleep center with a prescription and obtain their equipment from a DME. Patients then are left with many moving parts sitting at home, with humidifier, hose, dozens of different mask options, dozens of chin strap and soft cervical collar options, different bed pillows, device settings like ramp and mask type and auto versus manual start and stop and so forth. And they experience, and this is my experience, multiple possible challenges, including acclimation to therapy, comfort versus efficacy trade-offs, and climate-dependent mask rainout, hose anchoring challenges, mask and mouth leaks, mouth breathing, nasal congestion, sleeping position, leg movement, and others. So it's really no wonder that PAP compliance is poor overall, I would say. And it would be great if sleep centers could provide 24/7 support to patients with all these issues,
Yeah.
with techs and staff who are well trained and have personal experience. But it'd be great if they had unlimited capacity for in-lab study and titration. Um, but in fact, the fact is that the sleep centers have limited resources and are reimbursed by insurance companies for a limited and restricted range of services. And then if we look across the world in a global community like Sleep HQ, in many regions of the world, sleep center and sleep physician appointments are months-long lead times.
Yeah.
Patients are allocated 1 or 2 appointments to get everything right. And in some other regions, and we encounter patients like this on the forum, they're left completely on their own with PAP as a do-it-yourself project, if it's available at all. And so I think that online forums fill these gaps at scale by providing a global cohort of experienced and successful PAP users who are ready and willing to help at no cost to the patient or no cost to the medical system and to the insurance companies. And I think Stuart has his own perspective.
Yeah, well, I have to tell you that hearing you talk about this makes me feel like we have thrown all of this equipment like into your arms and you're kind of struggling to even carry it out to the car. And I feel like maybe in my mind, I feel like I kind of thought a lot of that was done with the various DMEs. But I also can appreciate that since reimbursement has declined, that their bandwidth has probably also declined. And so probably a lot of it does fall onto the patient's sort of lap.
I think you're exactly right.
Yeah, I think that in my case, the DMA instructed me how to use the machine when I picked it up
Mm-hmm.
and put a mask on my face and turned it on and made sure I could use it. But it really wasn't dealing with all the other surrounding issues. And they were available by phone if I called, but it was very difficult to get a hold of them. And I would say that they weren't really prepared to provide a lot of assistance. But Stuart, what is your experience with that?
Yeah, Stuart, what are your thoughts about all this? Is this how it works in Australia too?
Well, I think it works everywhere. I think you're exactly right, is that we get given the equipment and we get a short appointment and we've got to try and take it all in. And we go home and we go, well, what do we really do? It's definitely an unknown. And I think that's the obvious role for the forums is that
Mm.
the empathy, the encouragement, the support, the leading people through. And that's a really important role because it's there when the person needs it.
And
And
so is
it's
that how
there
you
from
stumbled upon this? Is that you were struggling and then you kind of found this online?
No, I'd been using the CPAP for about 4 years before I
Okay.
found the online community.
Oh, is that
Um,
right?
yeah, I actually came onto these forums when I had to switch machines from the Dream Station to the ResMed.
Oh, sure. Yep.
We all know why that happened.
Mm-hmm.
Um, yeah, and what I did at that stage was find out information there. And what I stumbled onto was a whole range of sort of different ideas and solutions. And some of the problems I was having are solutions that the doctors and the supporters people weren't telling me.
Mm.
What we found, and this is one of the big things about the forums, is that some of the ideas we get are not yet proven by the medical industry, but they do work. They may not be entirely known to the doctor, some of the doctors.
Mm.
Um, and actually, some of the ideas are really, really towards the cutting edge, which is a little ahead of what's been proven and approved by the medical system. And
Okay.
so, people want to be doing that, and they're trying to get there as well. Um,
So tell me what is the data that you're looking at? Is this from the stuff that you get like on an AirView or like from the card? Like what are you looking at?
we pull it from the card. It is exactly the same data that has been seen on AirView.
Okay.
Yes, and then of course there's also other devices that data can be uploaded, including oxygen saturation and heart rate from rings and data from smartwatches that show sleep architecture. So, and the particular platform that Stuart and I are on integrate all that data together and view it on one visualization, and you can see the relationship.
Yeah, sorry. So walk me through that. How do you get it to synchronize?
Well, all of these devices that I mentioned have internal clocks and metadata that's attached with the time information, and it's a little bit strange. ResMed machines, even though they're cellular connected, sometimes their clocks are off by several minutes,
Yeah.
as much as 10 minutes, and they don't change their clock when daylight savings times comes along. So usually if you really want to carefully synchronize them, a little more work is required. The Sleep HQ provides a time offset configuration that you can use to change the offset between the CPAP data and the other data. And also, if you encounter a daylight savings time switch, the users have to go in and reset their clock on the ResMed. And I don't know why that's the case because since it's cellular connected, it could be a little easier to use than it is.
So if I'm hearing you right, it sounds like you can look at like a ring device, so oximetry, and like a watch, like a Apple or Samsung or whatever, and your CPAP data, like sort of side by side or on top of each other.
Yeah,
Yeah, yeah,
that can all be imported into one series of charts. So we just look at a series of charts, one below the other, with different measurements from the CPAP machine itself or from the oximeter. Sleep stages. In Oscar, you can also bring in sleep position from some devices. So yes, you've got a range of information and it should all be lined up
So you
correctly
talked
for,
about like, well, you talked about DIY CPAP, and it sounds like this is sort of a DIY sleep test.
I guess it is. we do it every night.
So I guess what I'm kind of wondering is, what is the resolution? Like, do you see it one night at a time? Can you go to breath by breath? Like, how much detail can you get?
So generally when we bring up the charts, it'll show us the whole night, the whole time span.
Okay.
And we can zoom in on that right the way down to a minute, or in some cases with Sleep HQ, I can zoom in on a single breath.
Huh.
Um, so time-wise, the resolution is variable. We can look at it, we can scroll along from left to right, and we can go through and see the whole night's data as we wish, or we can zoom on a particular period, or we can zoom well and truly out. And then, of course, we also have the same trend data that the specialists generally get for our appointments.
So, if I'm understanding this correctly, then does this platform, is it where the data live, or does it use AI to provide clinical insight? Like, what is the purpose of the platform?
well, it really is where the data resides and where it's
Okay.
visualized by anybody that wants to look at it. And one of the really nice features of Sleep HQ, because it's cloud-based online, is that the patient can create a share link and they can share the data for either one night or their entire account on the platform with others. And that's often used to get comments from other users and super users like Stuart about their therapy and the improvements that could be made to their therapy based on that data. And also, the share link can be sent by email to anybody. So, for example, it could be sent to your physician
Huh.
by email.
Is that so? Is Oscar the same sort of idea?
Well, Oscar is the same sort of idea, except it's not online. The data is stored on the user's computer, and so the only way, as I understand it, maybe Stuart will correct me, the only way to share the visualizations that you see, which are extensive, but the only way to share them is to basically do a screenshot. Is that right, Stuart?
Yes, that's the way that's done on forums. You can, in theory, share your data card. You have to load it up to someone or transfer it with file transfer, and then they can actually open up in a profile in Oscar for you. So you can give someone the full detail, but it's a bit more of a process.
So are Oscar and Sleep HQ comparable, or do they work together?
They're comparable.
Okay. Okay. And so one's web-based and one is just lives on your computer.
Yes.
I think there's a big difference between the two, and one being Sleep HQ is a cloud-based online service where all the data of all the patients is accumulated, whereas Oscar is on each data's computer independently. And the Sleep HQ approach offers a lot of other opportunities, I think only some of which have been taken advantage of thus far. But for example, they've already started doing analytics
I wondered. Okay.
where they can look at all the data across a whole large cohort of 100,000 plus users. And they've done that, for example, in comparing different masks. And they've rated masks as a function of the therapy outcomes using statistical measures, and and have come up with a list of rating masks from the best to the least, and determined, for example, that the consistently best masks are those based upon nasal pillow,
Mm.
and that, of course, has challenges associated with it, with mouth breathing and mouth leaks and so forth. And one of the big activities on the forum is advising people how to move to a nasal mask, and if they do move to a nasal mask, how to manage their mouth leaks, and using mouth taping and vehicles like that. So there's all kinds of opportunities, I think, in Sleep HQ that come from the fact that we've got all this data accumulated from multiple patients.
So what happens if somebody switches from a full mask to a nasal mask and then they need a lower pressure setting? Does that then go back to the clinician, or do you change it on the platform?
Well, it isn't changed on the platform itself, of course, but as you know, the patients who are in the know, and anybody who's on one of these forums is in the know.
That's
These
fair. Yeah.
patients, these patients can access the clinical menu and make changes to uh, pressure settings themselves, and they can get a lot of advice from other knowledgeable users and super users like Stuart about how to go about doing that. But we do encounter other patients on the forum who do say, "Well, no, I don't want to do that. My sleep center and my sleep physician won't like that. I want to go back to them." But in that case, the forum can provide them with expert guidance that they can use to
Mm.
inform the discussion with their physician.
Yeah, it actually always makes me smile when somebody has a pressure of like 7.6 or something like that. And honestly, I don't mind. Because to me, this is sort of like it's a partnership, right? And if 7.6 is your pressure and this is what you figured out, great. Let's make the prescription match. So that we're all on the same page. So, yeah, I don't mind it. I usually will have a conversation just saying, "Okay, well, this is what I'm concerned about if we go up too high, too low, just keep an eye on this. And I think it's just sort of an informed conversation.
Yeah, I worked with the sleep center throughout this process, and they were tolerant of me changing the pressure settings, and especially as I was advised to to do weight loss, which
Mm.
I did, and as I was able to reduce weight, the pressures were too high, and as my apnea intrinsically improved on its own, and so I had to reduce the pressure over time, or at least it was desirable to reduce it over time to track my weight loss, and I was able to do that myself.
Stuart, what were you going to say?
I was going to say, I also make the point, and it's a matter of forum etiquette, which maybe not everybody follows. But
Okay.
when I'm trying to help people, I try to give them some suggestions of settings or changes that they can test for
Mm.
themselves and make their own decisions. So I don't want to be in control of the person's machine. I leave that to them. And if they involve the doctor, or the extent to which they involve the doctor is up to them and their ability to do so.
So, we've talked a lot about orthosomnia with wearables. Um, do you see orthosomnia with even more of this data that's available?
And I'm going to make another point about my etiquette, and maybe again, this is me personally.
Yeah.
To me, orthosomnia is a diagnosis, so I certainly cannot tell people they have that.
Mm,
Um, as a term, it was reasonably new to me just recently. We do see people who are very fixated on their data. And we do have regular conversations about you're reading too much into this, just relax, have a look at the trends, settle into what's going on. One night is not a problem,
yeah.
and all of these conversations. And I think that's actually a really important role for forums to play.
I think you're right.
Insomnia is not really something that clearly shows up on charts.
Mm.
We can see periods where they're maybe not asleep and they've had a break, but sometimes they've just had a bit of a leak and taken the mask off. We don't know whether they're awake or what's happening during those periods. And so for us to put together a bit of a fixation on data with insomnia and to turn that into orthosomnia, I think is beyond our abilities within the forum.
Yeah, I would say that if we take orthosomnia as a generic term implying anxiety adversely affecting therapy outcomes, that actually a lot of what happens on a platform like Sleep HQ or using Oscar for new PAP users is to reduce anxiety rather than increase it, because on the platform they get a lot of support and encouragement from other patients who have been successful. And as they're getting practical therapy guidance in choice of mask control and how to reduce leaks and dealing with position and movement and things like that, it's actually increases their confidence, which I think reduces anxiety. And then I think as they see it's kind of a process of continuous and systematic improvement of their outcomes in terms of symptoms and so on, which was my experience. As long as that's happening, then I think it's actually anxiety reducing.
Mm.
But
That's fair.
then, but then if you have, we do see, and I think Stuart can describe um, users on the platform who've kind of optimized and done all that they can do to improve their therapy, and yet they're still looking there at their individual breath waveforms and concerned about this or that. And that, of course, I don't think is a very constructive thing. But Stuart, you've seen users like that, right?
Yeah, you certainly get people who are zooming in and say, what happened last night or what happened at this moment in time during the night? And unfortunately, a lot of the time is we don't know. Some of the time we can take a guess. And most of the time we go, well, if it was only one night, it's not a problem. And that's what we try to do, is just sort of talk them down and say it's a bigger picture, relax. Sometimes show things up, but really anything that you're doing has to apply to the whole night. To try to focus on a short period is not specifically helpful unless it's a pattern that happens night after night.
Yeah, I would say that most patients, before they get to that uh, level, and let me call them users rather than patients, because we're not physicians or sleep centers ourselves, but most users, before they get to that level, um, either drift away and stop using the platform, or in a number of cases, stay on the platform, but with the goal of helping other people because it feels good and they like to use their knowledge to help other people, but they're not really obsessive about their own outcomes.
So let's take a short break. And when we come back, we'll talk more about patient facing PAP platforms. You're listening to Talking Sleep from the American Academy of Sleep Medicine. Welcome back to Talking Sleep. We're talking with David Messerschmitt and Stuart Crisp about how they use patient facing platforms to help others with sleep disordered breathing. So, one thing I see on Reddit a lot is people talking about upper airways resistance, which, of course, I love hearing people talk about this. Is this something you can see on the data that you can look at?
So once again, I'm going to make a small distinction there that upper
Yeah.
airway resistance, and particularly as a syndrome, is a medical condition. So
Yeah.
I'm not looking at it in that way.
Okay.
What I see is flow limitations.
Fair. Okay.
And
That's fair.
That's the same thing. So I will be talking about flow limitations.
Yeah.
And yes, we definitely clearly do see that the shape of the wave is something that's quite important to look at. Zooming right in, I'll go into about a minute time window.
Okay.
And what I'm looking at is to see whether the top of the wave is flattened or whether the inspiratory part is some way misshapen. I'm looking for a nice inverted U. And if it's not, then we suggest that there may be some flow limitation happening. To a lesser extent, we're looking at expiration as well, but it's mostly
Mm.
inspiration that gets talked about.
So do you base that just on flattening of the inspiratory limb, or do you also pull in wearable, like heart rate and that information?
Mostly the flow limitation that we're looking at
Okay.
is the inspiratory limb, because I'm looking at it from the point of view of physics, where increased flow is related to increased differential pressure and reduced by increased resistance. So that's not really something related to pulse or anything else like that. And that perhaps is starting to tie it together as a syndrome, whereas what I'm trying to approach is just the breathing aspect of it and the response to pressure and pressure support.
I appreciated how you explained it when we were preparing for this, how you explain it to users that they woke up because their breathing was hard, even though it didn't technically stop. And I thought that was such a lovely way of describing this. And I think I might steal that actually.
We do see that. I'm not normally talking about waking up very often.
Yeah.
Sometimes we're waking because of leaks. That makes a big one.
Hmm.
What we do see are the arousal breaths, the rarer type idea. And of course, we
Yeah.
don't know that it's technically a rarer, but we do see the flow limitation, the flattening of the waves beforehand, followed by one big deep breath and some disrupted breathing afterwards. Sometimes you'll get a CA in a clear airway event. And that's a disturbance. And they may not be fully waking, but we see patterns of these in the breathing. On the whole night breathing chart, we see spikes all the way across the breathing. And so we suspect that the person's not sleeping well because of those.
So, what about when you have events around sleep onset or wake onset? Like, tell me about the logic behind these events and what you see.
Yeah, these ones are tricky. What we see are clusters typically of clear airway events. And this comes back to the fact that we're looking at the whole night of data. Instead of seeing a single clear airway index and a number, what we can see is they're all clustered very much at the beginning or very much at the end, and the period of sleep in between is quite consistent and not too much of a problem.
Mm,
Um, the term that gets thrown around on the forums is sleep-wake junk. And that junk theory is that it really is in that transitory phase. It isn't affecting your entire night's sleep.
yeah.
It's seen as something of a nuisance because it affects your AHI and skews the impression that your sleep is poor, when in fact your sleep is pretty good. It's just the transition that's not. Um, but realistically, I think it's fairly poorly understood, and there's not a lot that we have in terms of effective strategies. We can play a little bit with RAM and suggest a few things like that. But it is an area where I think people tend to write it off under that junk heading and tell people to look past it and focus on their period of sleep.
Well, I like that you called it junk because you're sort of not you're making it less important.
Yeah, we're trying to take away people's focus. I've got this huge number of CAs, or clear
Yeah.
airway events, and we go, well, yeah, but you're not asleep yet. Don't worry too much about it. You're transitioning from being awake to asleep.
Well, and that's exactly what we call them on a sleep study. We call them transitional events, transitional central events.
Yeah,
So,
so
yeah.
and this is the advantage. Going back to something you said earlier about how do we use and what's the purpose of looking at
Yeah.
the whole night charts. We see things that aren't visible from the statistics. So sleep-wake junk is one of them. We can see things like clusters of obstructive events. So again, it looks like a person has a very high obstructive apnea count. But those are clustered together. They're likely to be positional, and they're actually unlikely to respond to pressure anyway. So it's important to know that they're happening and approaching them differently. And we can sometimes see difference between obstructive and central breathing just by the envelope of the breathing curve. Um, Clear airways are interesting. It's important to distinguish between the sleep-wake junk, the stuff that's post-arousal, or the CAs that are part of a periodic pattern of breathing.
Yes.
And we
Yes.
can see that from the NICE charts that you don't get from the statistics. We can also see how the pressure is responding to flow limitations, snore, obstructive apneas, and what's going on, why you have the pressures you have. So yeah, there's lots of data and lots of reasons for looking into the whole night data that goes beyond the statistics that come out of, just the sleep report on the front of the machine.
Yeah, well, that's it, right? When you're just looking at the AHI that's over the night, but I appreciate the detail. And I remember, that, we can see breath by breath too for the last maybe week, depending on the machine. But I don't know that we do it as often as maybe we should. I don't know. What I was thinking when you talked about clustered events, you talked about position, I was thinking about REM related events.
Yeah.
Yeah. And then I assume you can also see desaturations if they have a wearable as well.
Yeah. So if they have if they have an oximetry ring, then we can see the desaturations and line them up with what's happening in their breathing. REM is as good as our ability to identify REM as a sleep stage. If they have a wearable and the wearable is accurate with their sleep staging, that's a bit easier.
Yeah.
There are some indications in the charts. Again, an oximetry ring provides pulse, and that's very helpful, but otherwise we're looking at the respiratory rates, tidal volume, and minute vent tend to give us a clue of when you're in REM.
So what position sensor do you use? When you talked about positional apnea, are you talking about a wearable or is there another device?
Position, what I'm wearing is an old iPhone that I strap to my chest, and I run an app called Somnopose. And
Oh,
if you've
tell me
got an
about this.
Android, you use an app called Taurina,
Okay.
and it works like the night shift belt. It monitors your
Okay.
position, and if I set it, it will set a vibrator or an alarm when I'm on my back and helps to keep me off my back. And the advantage of the app is I can pull the information off and put it into Oscar as well, so I can relate position to what's going on in the charts.
Oh, can you really?
I might add that the new users that come on the platform, very common, that the first things that we pick up looking at all their charts and so forth is positional issues, sleeping on their back part of the night, and also leaks of various kinds. And so a lot of the initial discussion is all about how do you learn to become a side sleeper? How do you monitor your position? Um, and how do you use some of the devices that are available for encouraging side sleeping, and all of the issues surrounding where the leaks occur and what mask do you use, and how do you adjust the mask, and various things, and of course mouth breathing if they're attempting to use a nasal mask. And so that's a lot of the initial discussion. And then typically what happens is after you get past all that, then you get into the pressure issues. Is your pressure correct? Can it be fine-tuned? And can it be better than it is? It's important not to worry too much about pressure kinds of issues until you've gotten those other things solved.
So if I'm understanding, I'm stuck on the Somnopose. So you use an old iPhone, and do you put it in a belt? Like, how do you make it stay just in a pocket? How do you make it stay on your chest?
There are a couple of tricks there. People
Okay.
tell you to use a money belt. What I did is I went and bought a couple of elasticated luggage straps and bodged it together so that it holds in place.
Okay, I was
You
not
do
expecting that.
you do get running straps and things like that, or you can buy some sort of
Yep.
strap. I think everybody has a different solution, and I'm aware of that. I always suggest go get an iPhone and strap it to your chest. And I don't actually go into detail of that because I know what a problem it was for me to first work out where to get these straps to hook together in a way that would hold the phone in place.
Okay, I
But a
was
common
wondering about that. Okay. So you had also talked about chin tuck.
Yes.
So tell me, how do you, because I remember seeing this many, many moons ago in the sleep lab where somebody's head kind of flopped over and they had, event after event after event, and the tech went in and just sort of gently pushed his head back up and his apnea went away. And that was, during my formative years. And so this always stuck with me. How do you figure that out on the data that you look at?
We'll see quite a close cluster of typically obstructive apneas.
Okay.
So any cluster of events is a bit of a target of attention. Um, it's generally obstructive, not central, although I do know of someone who has been helped with their central apneas by using the same philosophy. And so what we think is happening is the person's rolling onto their back. So chin tuck is generally positional. Their pillow may not be great for them. And so what's happening is their head's been pushed towards their chest and their chin towards their chest. And so they are obstructing their airway in the process.
And so what do you tell
Solution
them to
for it.
do?
Well, solution for it's an interesting one. We tell them to go to a pharmacy, buy a soft cervical collar and sleep with it. And the results can be absolutely amazing.
Huh. And so they just sleep with a soft cervical collar and it
Sure.
keeps their chin from tucking.
Sure, I do it every night. I wear a soft cervical collar, small foam collar,
Okay.
and it helps keep my neck straight. I may not need it at this stage, but it's certainly something I used in the early days. It has the added advantage, it keeps your jaw closed, so it helps with leaks.
Okay.
And so the difference between that and a chin strap is that the collar does both duties of keeping your mouth closed and preventing your chin from tucking to your chest.
So, as an example of the kind of discussion that goes on in the forum,
Mm.
you get into soft cervical collar. You suggest that somebody uses that, and immediately the conversation heads off into, well, there's multiple different brands and styles of cervical collars that are available, and which ones are the best. And then you typically multiple people who've been using such collars jump in and relate their experience, and then hopefully that helps the user to arrive at a suitable solution for their own circumstance.
So let's get into some detail that I didn't realize that you could see. So I think you had termed this high level waveform forensics. Tell me about that.
Yeah, I'm not. That may have been something that David's describing. I don't know, go as far as forensics, but we certainly see useful things. One of the
Yeah.
big ones is we can see leaks, and that's very useful. We can distinguish between mouth leaks, mask leaks, and holes in tubes. So there's a difference in the pattern and the way it looks on the charts. So we do see that. As I say, we've already gone over the flow limitations. We can see the difference between obstructives and centrals to some extent. Something that crops up quite often is we see a pattern of breathing, and this is more an expiratory limb, but it gets termed palatal prolapse. I don't know if that's the
Okay.
correct medical term, but we can see that quite frequently. We don't have any real solutions other than position. And then, well, that and the other suggestion there is go talk to your ENT and see if there's something anatomical that needs to be looked at. And then we can dig into other aspects. One that I see quite commonly is that the machines report inspiration and expiration time, and those are frequently wrong. So by checking in on the breathing wave, we can confirm that. And the significance of that is that if we're working with a bi-level, then having the wrong inspiration time is suggestive of premature triggering.
Mm. So it's funny that you say to check with your local ENT. So I actually did check with one of our ENT colleagues because I wanted to ask, we had kind of gotten into this conversation about palatal prolapse and what that looks like, right? That sharp vertical drop off at the end of the inspiratory wave and then epiglottis collapse. And so I asked him what he thought about this, and he said, yeah, they've been popping up in the literature. They haven't necessarily been validated with a large effort, but he was saying that maybe there's a case to be made that when you have the lingual and the laryngeal surfaces of the epiglottis, that maybe PAP is hitting both sides and doesn't necessarily open it up as much as it should. And that may just be because the pressures are so high. And so, it was an interesting kind of hearing it from you guys and then sort of checking with one of our ENT colleagues, because I'm a pulmonologist, so I rely on my ENT colleagues. But he was kind of, suggesting that, yeah, you can sort of see these waveforms. They just haven't been largely validated. So
Well,
interesting.
I think that palatal prolapse illustrates something that happens fairly often on the platform, which is you can see some suggestion of possible cardiac issues or pulmonary issues or issues that need to be addressed by ENT, and so you can suggest that patients see different specialties, which may be something that is or is not suggested by their sleep physician or their sleep center. So I think that that's a kind of a valuable aspect of having this large community looking at the data.
Yeah, they're very, that's true. I mean, it's a good suggestion, right? That, oh, well, we see something, maybe go see ENT.
The other thing about palatal prolapse is that it's not across the whole night. It's only in periods. And that's one of the reasons why we suggest to people that it could be positional.
Mm.
The other one is that we do not see that as people try to change pressures to respond to it, that is terribly effective. And when we do tell them to use a positional therapy, we tend to get better results.
Oh, that's
It
interesting.
happens, and it doesn't only happen on your back. I see it in my charts every now and again, but I only see it for short periods of time, and I don't let it bother me.
So, what about periodic limb movements? Can you pick those up?
Not really.
Well, in that case, there's not a whole lot we can. I don't. I think Stuart will say that he doesn't see too much evidence of that on the charts that we see, but I think that it's not an uncommon suggestion on the platform to suggest to patients or users that may um, sense that they have an issue along those lines to set up a low-cost security camera and do time-lapse video of themselves at night. In fact, done that for myself,
Huh.
and in fact, I could see leg movements, and I took that back to my sleep center, and my nurse practitioner at the sleep center prescribed me some gabapentin, to address that issue. So um, that's an area where the data that we see is not really adequate. I think Stuart would agree is not really
Mm.
adequate by itself, but we can suggest other ways that patients can investigate.
Yeah, we've got nothing that measures limb movement. The oximetry rings have a movement sensor, but that's on the hands, not on the feet. We have had the strange suggestion from people to wear the oximetry sensor on their toes, and I think there have been people who've done it.
Huh.
But in the charts, there's not a lot that's there. We tend to suggest it when we are seeing arousal breath, so this pattern
Mm.
of a deep breath and something going on. And if it's not got flow limitation beforehand, we scratch our heads and say, we don't know what it is. Maybe it's limb movement. We are amateurs. We take our guesses. We try to work things out as best we can, but that's all we can say. I'm not aware of anything that tells us that. We're always willing to learn, but we need somebody to learn from.
Well, and I think that's what I love about our field is I feel like we're very collaborative, right? We all come at it a little bit differently, and we all learn from one another. It's interesting to me that you've added now a camera for to look at limb movement. So yet another DIY sleep study, right?
The camera was also my first way of measuring position.
Oh, okay. Yeah, that makes sense. So I will tell you what you guys taught me when we were preparing for this. So I've always known that you can turn a bilevel PAP into a CPAP by setting IPAP and EPAP the same. But you taught me that a CPAP can be turned into a bilevel PAP.
Yes, this is where I have to be a little bit careful about that
Yeah.
because it's quite a controversial topic about
Okay.
whether EPR is the same as pressure support.
Okay.
Um, I often say EPR is about the least understood setting on the AirSense machine. ResMed describe it as a comfort feature.
Yeah.
But the thing is that when it's used and turned on overnight, we can see distinct differences in the therapy. And we attribute that to the fact that it's increasing minute vent, which is overcoming flow limitations. And the relevant of that is that flow limitations drive the auto algorithm to increase pressure. So we don't see the same ranging behavior of pressure by using EPR. Uh, Now, if you look at it mathematically, EPR and pressure support are pretty much the same. But I'm going to emphasize this bit about limited bilevel therapy because there's no other bilevel settings. It's limited to three. An AirSense is definitely not a bilevel machine, but there has this ability to come into it. I'm also going to point out that when we're talking about this, we are comparing it to a V-Auto machine. And so the Australian listeners need to either block their ears or learn something because we don't get V-Autos in Australia.
Okay.
And it's a very common thing in Australia. They're adamant that bilevel and EPR are not the same, and they're correct because what we have are it's either air curve or Loomis machines, but the S, ST, and STA varieties. And the difference between those machines and the V-Auto, and in fact the AirSense, is a feature called Easy Breathe, and that is a big difference between the two. Easy Breathe affects rise time. So yeah, I describe EPR as providing that limited bit of bilevel therapy similar to the V-Auto.
You had shared with me that it is not a hardware issue, it's a software issue.
Yes, well, at the moment we're just dealing with pure settings that it's there.
Yeah.
But then beyond that, the hardware is, as we understand it, essentially the same between an AirSense and a bilevel. Now,
Yeah.
ResMed I'm sure will be quick to point out any differences, but there are people who are doing some interesting work to get past that, and they are finding ways to turn their AirSense machines into bilevels.
Yeah, that I had no idea. The EPR, yes, but we kind of mini bi-level, but the software part was very enlightening. I learned that from you guys.
There are probably some ethics issues around some of those. So
Yeah. Yeah, I would agree. So I feel like a lot of these platforms and communities have arisen because of a need that we aren't meeting. And so instead of this sort of being antagonistic, where it's, oh, the sleep center is not helping me, I'm wondering, how can this be more collaborative? How can we start seeing some of these details, and how can we partner with our patients to do this? And again, we struggle, right? Because our time is so limited.
yeah, look, I have to agree. Forums definitely fill a need that the medical community does not, probably cannot, and in some cases, I think should not.
Mm.
The people are there are the people who are motivated to take action to improve. So that's the first thing. And they often prepared to try things that wouldn't necessarily be encouraged. And unfortunately, what we do see in the forum is a reasonable set of horror stories of why they're there and what's gone wrong.
Mm-hmm.
Um, the thing about the forums, and this is where what is useful for the medical side to understand, is that the people who are there answering the questions are there just to do their best to help. There are different personality types and traits that come into play, and forums are interesting places, and we often look at someone and wonder whether Dunning-Kruger effect is at play.
Yeah.
But the three ways I've come up with that really are helpful is that the forums do the best with the knowledge they have. A lot of people are basically poorly informed. They're very keen to learn.
Mm.
And so getting access to a body of knowledge is something that would be really, really useful, because then we are presenting better information. We're not presenting some of the rumors or stories that are unproven or uncertain. And eventually that may come down to sort of training materials and courses and stuff like that. Because the other thing that's difficult on a forum is for someone who comes and asks a question is to know who to listen to. They'll get 5 different opinions and very different opinions, and which one's correct.
Mm.
So again, a method of establishing competency, I believe, within forums would be useful, and perhaps the medical community supporting that as well. The other big one is, well, we need to put that question back onto the medical community and ask what they want from the forums.
Yeah, that's fair.
The big idea here is that maybe the AASM is exactly the right association to put together some sort of working group between medical community and forums to try think this question through.
Yeah, I mean, I feel like in the last, probably 10 years, we've had a lot more involvement from patient representatives. I've learned a lot from our colleagues who are living with narcolepsy, for example. and what, cataplexy feels like, and even, sleep apnea, like all of these things that you've shared. Like, just think about the lengths that you've gone through. So now I'm picturing you with a soft cervical collar, and then you've got this luggage belt around around your chest, and then you've got a camera set up in the corner, and like you're looking at all of this information. And clearly there's this thirst for knowledge.
Yes.
And I think one of the things we have learned with, all of the social media is that it is really important to have vetted information out there instead of just trying to sort of, tackle one tiny thing at a time as it pops up, like mouth taping turned into a big thing. And
Yes.
so there's, I think, room for partnership.
I also feel a bit interesting when I get doctors come onto the forum, and there have been doctors come in to seek help and information. I
Mm.
kind of have a bit of imposter syndrome of why are you asking me? You're the person who should know this. But
you know,
realistically, what I'm doing is something different. I'm
yeah,
doing my engineering skills reading charts, and that's not really a medical skill. I'm sure it's not taught to you in medical school of how to go and read and interpret a
yeah.
trend line across a period of time. Um, and I'm certainly helped with my background by having programmed control systems. A CPAP machine is just a programmable control system. So
Mm.
I have some understanding of how the software is done, or how the data is stored in a historian and represented in a chart, and things like that. So yeah, it's very interesting to see the communities. Definitely there is place for it, and some of the doctors have found their own way and found some help in the community as well.
If it makes you feel better, I get imposter syndrome every time we record one of these. So are these platforms only for patients, or can physicians access that information too?
The platforms can be used by physicians as well. In the case of Oscar, it's a case of installing the software, getting the data, and creating a profile. That's on your own machine, and that's pretty easy. In the case of Sleep HQ, I understand, well, there is a clinician's account, and I looked on the website and couldn't see a lot of detail about it, but I have seen it, and what it does is give you access to the patient's information in exactly the same way as the patient sees it. It's also got some facilities to keep additional information about the users, about their sleep studies. And so it is available. I don't know the details. The best I can suggest is that you contact Sleep HQ directly
Mm.
and say, I'm a clinician, what can you offer me? As far as I know, it's free, by the way, but I'm not sure of that.
Well, and I think it's an important, setting expectations too, that maybe this is something we review together in the context of a clinical visit rather than asynchronously, because I can see how that would just open the floodgates and overwhelm the already stretched clinical staff. But maybe just having, setting aside that time during the visit to review it together, I think would be meaningful and helpful.
Well, all of these platforms are simply software based, and any features that are desired can be added. So if there's any kind of um, way in which physicians or sleep centers could have access in ways that would be beneficial, that can always be added.
That's a really good point. So, Dave, tell me about the role of the forum and how it kind of helped you with your own education.
Yeah, I actually think that patient self-education is a really important part of successful outcomes in medical therapies or medical treatments where you have um, conditions like sleep apnea, particularly where there's a very complicated at-home part of the equation. And being 80 years old myself, I'm very experienced with a lot of conditions and learning about them myself and having more confident conversations with my physicians. And I found that one of the reasons that for joining a forum like CBHQ and spending quite a bit of time helping other patients on the forum is the opportunity it gives me to learn about the various aspects of the therapies. And so I feel like that's a real important aspect of these kind of online forums.
In terms of patient education, something that's is important is to learn your own machine and take some control or some responsibility, at least, for your own therapy from that. And one of the things that happened is that I am at the position I'm at because I did that. And fortunately, I've got a better ability to do so with my engineering background. But I started out having desaturations 3 times a night, well below 90%. And I'm now at a position where I have a bi-level controlling my oxygen levels to nice, consistent 95 odd percent throughout the night. Unfortunately, I did a lot of that myself, and I needed to. And so the education aspect is important, at the very least, to drive the process, to learn which questions to ask of who. But in some cases, it may be necessary to take a bit of control themselves. But this, again, is especially around the sleep hygiene and the little bits on the side. If you don't educate yourself on the use of a soft cervical collar, you may never fix things like positional apnea, or you may never even know that you've got it.
So do you have any take-home messages for our sleep medicine community?
Well, let me take a first crack at that because,
Yeah.
and pass it on to Stuart. I think that, today really the only interface between these online communities that I'm aware of and sleep medicine and sleep centers is through the individual patient. And but I think that can be greatly improved on, and there's really an opportunity to conscientiously and proactively incorporate peer online communities into sleep medicine practice. But I would add, beyond beyond that, that specifically cloud-based communities, and this gets into my specialty in data science and so on, but cloud-based communities offer the opportunity to capture data across a longitudinal selection of cohort of a large number of patients, and that can be the basis for a lot of things we haven't had time to talk about today, but things like observational clinical studies and training of artificial intelligence for therapy optimization and things like that. So I think this is an area that's really ripe for opportunity.
Stuart, your thoughts?
Yeah, from my side, I'd like to highlight that the way we look at nightly charts using either Sleep HQ, Oscar, or any of the other software that's available, pretty well identifies, I think, a gap in the medical system. The detailed analysis of data is different, and it's useful. This type of work that I'm looking at and the charts I'm looking at. The summary statistics certainly do not tell the whole story. And a single night sleep study where the sleep tech is looking at data in basically 30-second epochs, maybe a bit longer, but they're not always looking at the whole night. I don't think that tells the whole story. And I think what this requires is a different set of skills and a far more technical set of skills than doctors probably have, but certainly should be expected to have. And I think that if the medical community is not filling that gap, then it's perfectly natural that a forum is going to step up and try to do so. Whether they do it well or not is a different matter, but the need is there. And to the extent that it is acceptable for a forum to exist and fill that gap, support with better resources or more complete resources would definitely help.
Yeah. I mean, I think I would push back a little bit in that I think the biggest constraint is not necessarily the ability, it's the time.
Yeah, this is definitely a matter. And I've had this conversation with my own sleep specialist when I've been talking about it. And she's fairly prominent within the Australian medical community for sleep. And I did say to her, I'm doing this on the forum and I'm helping one person at a time and I'm helping several people per week. But realistically, I could not do more than what I did unless I was paid. And the medical community cannot do what I've got unless there is a billing code for it.
Yes.
So I think it's important to first identify the gap, but also to identify the skills needed and then put somebody in there who can do the work and be paid for it.
Yep. I think you're exactly right. And maybe that's how we meet in the middle.
Yes.
Well, thank you both for joining us today. I really do appreciate you reaching out in the first place and for being willing to share these new tools that we can potentially use to help improve patient care in our sleep clinics.
It's been a pleasure. Thank you.
Well, thank you. It's been a great opportunity.
Thanks for listening to Talking Sleep, brought to you by the American Academy of Sleep Medicine. For more podcast episodes, please visit our website at aasm.org. You can also subscribe through your favorite podcast service. And if you enjoyed this episode, please take a moment to leave a rating or review. For more feedback or suggestions, email us at podcast@aasm.org. I hope you'll join us again for more Talking Sleep. Until next time, this is Seema Khosla, encouraging you to sleep well so you can live well.